Hi everyone, my name is Michael Smith. I'm one of the A&E doctors. I might be seeing you around if you guys decide to work weekends. I'm actually going into GP training, but I've worked here for quite some time, but I might be back on maybe a Saturday or Sunday, so I look forward to seeing you then. Anyway, we're going to be talking today about endocrine emergencies. So let's have a look through our objectives today. So we're going to be identifying some particular endocrine emergencies. I've listed them here. So we're going to have hypoglycemia, diabetic ketoacidosis, and hyponatremia. And then we're also going to talk about the initial management of these in the emergency department. So I must stress that my talk today is going to be aimed at what we would initially do in the emergency department, what you would do here before you would refer these patients on to be admitted to the medics. So it's our initial management, how we identify these patients and how we make them stable in the ED. Okay? So the first one we're going to talk about is hypoglycemia. So this will be low blood sugar. So the symptoms of this will be someone who's presenting, they could potentially be hungry, they might be sweaty, they could be shaking, trembling, and they can have some tingling around the nips, dizziness, they can have palpitations, that can be a heartbeat going very quick, they might look a bit pale, and they can also be a bit irritable as well, so it's also good to get a collateral history of these patients. Generally, people that are hypoglycemic or known to have hypoglycemia, they normally present with these symptoms well known to them, and they normally try and act on them at home as best they can, the diabetics. And it's when they come here that we then have to manage them. Okay, so hypoglycemia, if it's left untreated, it can cause blurred vision, confusion, loss of consciousness, and then ending up resulting in a coma. It can cause slurred speech, and sometimes that's presumed as a stroke, really, and people actually forget to test the glucose. And people also develop seizures. So a side note to all this, hypos can occur during the night. Patients that are on long-acting insulin or take insulin before bed, they can wake up with drenching night sweats and severe headaches and feel generally quite unwell, and that can be mistaken for an infection. Okay. So hypoglycemia again, ABC, you know, your management airway, breathing, circulation, but I don't know if you've heard the acronym DEFG, so it's don't ever forget glucose. It's commonly missed. The way we test for it in the emergency department is either using a BM machine, which is a finger prick, or when patients have their initial bloods done, they have a cannula put in, venous blood gas is taken, and at the very bottom of the venous blood gas you get a blood glucose measurement then. Okay, so there are two ways we can test it. Some patients may come in with their own machines they have at home and have a record of how much they've taken. You can actually look through that as well. And a normal blood glucose for anyone is 3.5 to 7 millimoles per litre. Okay. This is a side note into hyperglycemia. Someone presents with simple hyperglycemia, don't treat them with stat doses of insulin, just adjust the regular insulin dose. Okay, a lot of patients and nurses and doctors will get worried about an isolated high reading. That's just a separate side note. Okay, so how do we manage hypoglycemia? So we treat a patient if the blood glucose is less than 4 in people known to have diabetes, or less than 3.5 in non-diabetics. So there's two sort of pathways of management. The first one we'll talk about is a conscious patient. So if they're conscious, you try and increase their blood glucose orally. You have Dextrogel, you can use glucose tablets. There is something called a hypo-stop box in the A&E department, which the nurses know about, and that normally has some sort of gel or something similar in it. And even some people that can't swallow, we have a powder that you can mix with water and you can rub it into their gums as well. And that also seems to work. And then we don't do repeat blood gases because that would be lots of venipuncture and cannulas, but we just do a finger prick test with BMs. I would stick to the nurses doing that just because they've been trained to do BMs properly with the machines, and also when they wipe the finger, they don't wipe with alcohol gel, they wipe it with water and then let it dry to get a false measurement. So just ask the nurses politely to do a repeat BM for you, and then you can repeat that cycle a maximum of 3 times. Okay. If the BM remains less than 4 after 3 times, we can give some intravenous glucose. So we have different percentages of glucose in the department. We have 5% bags, 10% bags, 20%, and also I think we have glass bottles of 50% as well. So the management that we use here is 10% glucose, 100 ml per hour IV, and if they're diabetic, do not omit their usual insulin. and we normally admit these patients to a medical team, and they continue to regularly do their BMs 24 to 48 hours, and a DSM review. DSM stands for Diabetic Specialist Nurse. So there are specialist nurses in this trust who are trained specifically in diabetes, and they know the diabetics in the community very well and what the normal incidence on. They have their own set of notes, so they normally get a ward review. Sometimes in the working hours 9 to 5, we do have a diabetic specialist nurse bleep. You can get it through switchboard. And you can contact them, and they can sometimes come and see the patient and give you expert advice rather than referring to the medical team who might already be busy. Okay. Now, if a patient is unconscious, it's obvious we need to go through management of ABCDE. We stop any insulin whatsoever, and that's when you use a higher percentage glucose. So at 20% glucose, you can use around 80 mils into 100 mils. In those sort of situations, we don't really get a glucose pump ready. We just hang the bag up and we go through, and you can see the markings on the bag, and you let around 80 to 100 mils go through. And you can also consider giving intramuscular glucagon 1 milligram as well, and repeat the BM after 10 minutes. And these patients are normally admitted to the medical team as well, and when their BM gets a bit higher, we restart their normal insulin and encourage good oral diet, and again they see a diabetic specialist nurse or the endocrine team as well. Okay, so another endocrine emergency we're going to talk about is diabetic ketoacidosis. So this commonly normally occurs in usually type 1 diabetics, but can also occur in type 2 diabetics as well. But less frequently. So the signs and symptoms of DKA are polydipsia, polyuria. They're initially, when they first get DKA, present with very rapid shortness of breath, quick breathing, but then it becomes cosmal breathing, which is where they have deep laboured respirations, and the reason they do that is to try and blow off all the carbon dioxide due to the acidosis in their body. They normally got quite a fast heart rate. They may say they smell sweet breath. You might smell it on them, or a family member or someone who's with them might smell it on them. Normally quite tired, and things get worse where they can become very confused and they can collapse and become very unwell. So causes of a DKA, some of the main ones are infection. Some patients are non-compliant with their insulin and their glucose gets better of them. Oral steroids prescribed by us really. Pregnancy can cause it, alcohol, drugs, trauma, surgery, injury, basically the insults to the body that can cause this. And so the criteria, 3-4 things really. So the 3 things are hyperglycemia, the acidemia, and the ketonemia as well. So we have our own trust protocol here, which you can find on the internet, which has got all the criteria, what to do on the steps, and a step-by-step management as well. So if you do have a patient with DKA, it's best thing to do to print it out. But just in case, say the computer's down, the printer's not working, you can't find it, it is always good to know the first initial management of DKA and how you can identify someone with it. So we discuss signs and symptoms, and then we do something like a blood gas on them. And so their blood glucose greater than 11, some criteria say greater than 14. Ketonemia, so this is, it's the same machine or similar machine to the BM machine, but they actually use blood ketones, and if that's greater than 3, it's quite significant, and then normally have ketones in their urine as well. But some of these patients can be incredibly dry and not pass urine, so it's easier to just get blood ketones. And then acidemia, so if their pH is less than 7.3, or they have a bicarb of around less than 15 or less than 14. Okay, and if they're ticking those 3 things, then they're in DKA. You need to act quite quickly. So as I said before, check the trust guidelines, print it, start filling it out, put the details on it, and put it in the paper notes so we have a record, because it carries on up to the ward as well. And that's about it on that slide really. So this is something that I got taught by, when I was a student, by one of the AME consultants I used to train at, and it's a mnemonic. It's quite a busy slide, but I'll talk you through it. The mnemonic is PANICS. And it's the first hour management. So it's exactly what we would do in the ED to stabilise them and then refer these patients onto the medical team. So this is what we should be doing. So PANIC stands for potassium acidosis, normal saline, insulin culture, stomach aspiration. And I put numbers next to each one afterwards, which is the order that you should roughly do them really. So acidosis, so that was what we were talking about before with the pH less than 7.3 or bicarbonate less than 14, 15. So if it's less than, some trusts say 7.2, but I know our trust says 7, we need to call the intensive care doctors, because these patients are extremely sick. if their pH is less than 7. They become very, very unwell, and they need to have some senior support. The second thing we need to do is, so you've taken your blood gas, you know what the pH is, you've either told ICU or you've told your senior. The second thing you need to do is get fluids into them. These patients are normally really depleting fluids, so you give them a litre of normal saline. The guidelines normally say over an hour, but you can give it quicker than an hour. Sometimes with a pink cannula or a green cannula, it takes about an hour to go through anyway. The third thing you need to do is prescribe some insulin for the patient to get their glucose down. So, and try and get them out of DKA. The thing we do is here's 0.1 units per kilogram per hour. So either ask the patient's weight or weigh the patient. If they're really, really unwell, you can guesstimate. We give I think it's a no rapid here, so it's a rapid fast-acting insulin. There's no bolus given, and for morbidly obese patients, you can't give more than 15 units, so 150 kilos. The other day we had a guy in resus who's 142 kilos, so he has 14.2 units IV in 1 hour. So by this point, the patient's bloods have been done, fluid's been given, the insulin should now be in a syringe pump being delivered to the patient. With the insulin, it can reduce your potassium, it drives potassium into the cells, and so you need to think about hyperglycemia. So next time you maybe repeat a blood gas, if the potassium is a bit low, you can give 20 millimoles of KCl in your next bag of normal saline. Okay. And the fifth thing you need to start thinking about is, why does this patient have a DKA? Is it something we spoke about before, or is there an infection going on? So these patients need cultures from their urine, they need blood cultures, sputum if they're productive, they need sputum, and also the C, I put in a chest x-ray to look for any sign of a chest infection or pneumonia, and also these patients will need a catheter as well to monitor the amount of urine they might be producing, given the amount of fluids we're giving them as well, and to make sure the kidneys are perfused and actually working. And if a patient is vomiting, it's good to pop an NG down them as well. Okay. Side note at the bottom, do not stop your long-acting insulin. That continues regardless of the 0.3, the insulin there, the rapid, okay? So it's just a sort of thing I try and remember. First, our management, panics, acidosis, saline, insulin. That's what you need to get really prescribed and worked out in the first 5-10 minutes. And then you've got our trust guidelines, which you can simply run through. And again, these patients are normally referred to the medics and they take over their care. Sometimes they are quite unwell, these patients. They stay in the resus department for some time, so even though they might be referred to the medical team, it's always good to keep an eye out for them. For example, if the medical team's gone to the emergency, a crash call, and another bag of fluids is prescribed, you should always keep an eye on these patients. Okay. Next thing to talk about is something called hyponatremia, so low sodium. Normal reference range is 135 to 145 millimoles per litre. Signs and symptoms of hyponatremia are quite vague. They can present just feeling a bit generally unwell, non-specific symptoms, fatigue, headache, nausea. It's when the hyponatremia becomes very severe, when we're talking about less than 115, 110, they can become very confused, they can have convulsions, and they can actually end up into a coma. And what we'll talk about next is how we can try and manage this. And what some people have missed in the past is that when patients have a blood gas, when they first come in, when they have the bloods done, they either, the nurse either does a blood gas, or you do the blood gas, you put it in the notes, and you have a look at the pH, look at maybe the hemoglobin, you might look at the potassium, and then you look at the glucose and lactate, and okay, it's fine. What people miss out is the sodium. The sodium's right in the middle of all the results of the blood gas. So whenever you do a venous blood gas, I'd always read every single value right from the top, and normally the sodium will be low on a patient with severe hyponatremia, so it's always good to check that, rather than the yellow top, which the sodium goes in. It probably takes, on a good day, about an hour to come back, sometimes even longer. Especially if it's abnormal, the lab will rerun the test, so it might take an hour and 15, an hour and 20 minutes before you've got a sodium, and you've got a patient who's been in the department for an hour and a half, hour and 40, and you don't actually know that they're hyponatremic. So always check the blood gas number by number, and with the reference values right at the bottom as well. Okay. So hyponatremia is very common. It's the most common electrolyte abnormality that you'll find in A&E, in the hospital, and in the community as well. We don't really admit or treat patients unless the sodium is 125 or less than that, and unless they have severe symptoms, so coma, seizures, we correct the sodium very slowly. The reason we do that is because it avoids osmotic demyelination. So we try and really correct it by half millimole per litre per hour if they're really, really unwell. Okay, so this is how you manage hyponatremia when they're not having seizures and they're not in a coma, basically. So we treat it according to hydration status, and we'll come on to that a bit later. You have a look at the medication. A lot of the patients are elderly, can be on diuretics, thiazide diuretics, sugar, sodium. PPIs, omeprazole, lansoprazole, esomeprazole, pantoprazole can also be known to lower sodium, and patients on lithium as well, so psychiatric patients can be known to drop them. When you've already sent their bloods off and you know the sodium's come back low, it's really important that you send urine off. So you want urinary sodium, urine osmolality, and you want serum osmolality as well. So everything should be paired, so try and get that done at the same time. So bloods have been done, you've noticed low sodium, get some urine sent off as soon as you can, and add on a serum osmolality. So patients don't present saying, oh, I have low sodium. Some patients are known to have low sodium, but they normally present saying, oh, I think my sodium is low. So you can print out an add-on form for a serum osmolality and just add on to the bloods. And the same thing goes to a thyroid function test as well. You just add it on and it gets sent. And then something else that you may have all heard of is an actin test, but normally the medics do that on patients on the ward. So we're just sticking to our first hour management, okay? So, hypovolemic hyponatremia, so they're low in volume. So a good way of finding out if they're low in volume, if you can't tell patients, dry, reduced skin turgor, dry mucous membranes. A good bedside test you can do is the line and standing blood pressure. If there's a significant postural drop, then it could be the fact they're quite dehydrated. So this is quite, again, it's a slow thing to correct. So you prescribe about normal saline, regular sodium monitoring on the ward normally, and again, a max correction every 24 hours, so that's what the medics do. If it's not responding, you can consider hypertonic saline and even consider vasopressin, but that's only really an extreme symptomatic, so again, convulsions, things like that. So normally it's a slow bag of fluids, normal saline to try and get their saline up nice and slowly, but these patients will still get admitted to the medical wards. Okay. So euvolemic hyponatremia, these are patients who are not dry, not overloaded, they have a normal hydration status. This is something called syndrome of inappropriate antidiuretic hormone. So what we do for these patients is fluid restrict them. So normally they're probably around a 750 1 litre maximum fluid restriction a day. That includes intravenous fluids and oral fluids, and not just water, it's like tea, coffee. A lot of patients will be drinking loads of cups of tea, and they'll be like, oh, I don't drink any water, and I'm drinking 7 cups of tea a day. So it's always good to establish how much they're taking in, and then these patients get fluid restricted. They don't get really put on any IV saline unless it's hypertonic, again when they're really unwell, and they just have regular blood. So normally it's daily morning bloods on the ward until their sodium is corrected to a point where they can go home, and they've also managed to be able to maintain their fluid restriction at home and then get followed up with a GP. So hypovolemic hyponatremia. So this is normally due to a underlying condition such as something like decompensated liver disease, where they have massive volume on them, for example ascites. And the best thing to do is try and treat the underlying cause to fix their sodium, rather than just what we spoke about before with the euvolemic patients. So you still fluid restrict them, you try and reduce their dietary salt intake, and you have a look at a diuretic medication as well, and you can consider giving them some to try and offload some of the fluid. You have to be careful not to offload their sodium as well. And again, it's regular bloods on the ward for these patients. So this is something that you rarely see, but is an emergency that you can see in the emergency department. And it's symptomatic hyponatremia, so it's what I was talking about when they're having convulsions or in a coma. So sodium is incredibly low, sometimes less than 100 and 110, maybe 105, 101. And you always go through your ABCDE approach. So get senior help early, let the registrar in charge know. If they're consultants on the shop floor as well, let them know too. And then I'm not exactly sure what saline we have here, but you can consider 3% saline initially. Let intensive care know as well. And the way you do your saline is you weigh the patient, or you guess their weight and an hourly correction target. So for example, if the patient weighed 70 kilograms, you give them 70 mils of 3% saline over the hour. And you do blood gases on these patients. So before, when we said regular sodium monitoring, that's just on the wards in the morning the patient comes to do it. These ones we do blood gases, and you aim to increase sodium by around 1 in the first 3 hours in the department. Okay. So, as a summary for this brief talk, it's not an exhaustive list of all endocrine emergencies. There are other ones you can get, such as adrenal crisis, but these are the most common ones that we see here. Okay, so something really important to remember out of everything is don't ever forget glucose. So if the glucose is low, if they're diabetic, not diabetic, just go through that flow chart of how to give them. If they're conscious, you give it to them orally. If it's still low, then we can consider IV. Okay. Then DKA, you have to recognise those patients. The type 1 diabetics, sometimes type 2, very unwell, crystal breathing, tachycardic, pale, maybe vomiting, recent infection. Think about your first hour of management. So get a lining, get a gas off, get some fluids on, start drawing up the insulin, 0.1 units per kilogram per hour, maximum 15 units. If the pH is very low, get ITU involved on the phone straight away, get the patient in resus, and make sure you reference back to your trust guidelines so you can see it on the internet. It's quite easy to get to, and then print that off, get it in notes and start going. And hyponatremia, so it's 120. If it's 125 or less, then we need to admit the patient to the medical team, and you try and work out the underlying cause. So best thing to do is look at their hydration status. Are they dry, are they euvolemic, or are they really overloaded? So again, simple bedside test, lines on the blood pressure, skin turgor, eyes, mucous membranes, get some collateral history from the family. Have they not been drinking? Is it hot outside? Have they been drinking loads? Do they have ascites, peripheral leg edema, etc.? So work out that and then treat them as per that, okay? If the sodium is incredibly low and they're really symptomatic from it, such as convulsions, coma, then go through the flowchart before ABCDE. Get senior help early. These patients are difficult to manage, and each trust has their own sort of fluids they like to give the patient. From the guidelines, from the hyponatremia guidelines, it's around 3% saline that we give. Okay, and just some take-home points from my experience here in this department. If you're in doubt about anything that I've spoken about endocrine-wise or any other emergencies or something you're dealing with, just ask someone for help. Everyone's really, really friendly. And make sure you work hard, but have an enjoyable time in the department. And as I said earlier at the beginning of the talk, I'll probably be working weekends. So if you're ever working Saturday, Sunday, always come and see me. Feel free to help. I'm always, feel free to ask me for help if you need anything, and just have a good time. Okay. Make sure the Miguel gets the slides and you can send them to you. So you put a little PowerPoint booklet. And if you have any questions or anything, you want to email Miguel or one of the consultants about this, then feel free to. Even though I'm not here, I'll try and reply. All right.